For some reason, people find evidence-based medicine really intimidating. And honestly, that has worked out pretty well for me because it means that people are willing to listen to my interpretations, even my ramblings about the papers that I read. It means that I get to run a YouTube channel and I get to create videos about critical appraisal and people seem to actually listen. But I'm going to let you in on a little secret. Evidence-based medicine is really, really easy. With just a tiny amount of effort, every doctor has the capacity to be an evidence-based medicine expert. And so my goal today is just to change the way that we think about evidence-based medicine. Just a little bit, so that hopefully it becomes a little bit less intimidating and that more people will get involved. Welcome back to First 10 EM. Here's the thing. Everybody must practice evidence-based medicine. We sometimes talk about it like this is some kind of option, like there's a valid alternative. There is not. If you're not basing your practice on the best available evidence, you will hurt your patients. Science is really important. Now, of course, nobody goes out of their way. Nobody wants to practice non-evidence-based medicine. Well, we'll leave aside the handful of quacks, the Dr. Oz's of the world, but most of us, we aren't anti-science. But my question for you is, are you pro-science? Are you actively reading papers, thinking about them, trying to apply that evidence? And don't worry. The honest truth is that for the vast majority of us, the answer is no. We try to pick up evidence passively. We go to a conference, maybe we listen to some podcasts, maybe we go to a journal club a couple times a year. But ultimately, that system does not seem to work well at all. There's data going back decades that the average length of time it takes for new science to reach the bedside with your patients is something like 17 years. Hopefully that's getting shorter, but if you were a patient, would you want your doctor to be 17 years out of date? And why does that happen? It's easy to blame the tsunami of new research that's released every single year, and it is hard to keep up, but I honestly don't think that that is the problem. Because I'll tell you, I have spent my career now. I have been summarizing research for a decade now, and most people who listen to me don't change their practice. They've heard the research, so keeping up isn't the problem, but they still find it hard to change their practice. It's been more than 10 years since I first lectured about how heparin is probably harmful in NSTEMI. And I think I'm the only emergency doctor in my group who doesn't routinely prescribe it. It's been more than 10 years since I talked about the evidence that shows cardiac stress tests are probably net harmful. And yet almost everybody in most emergency departments still orders them. Everybody that I work with knows, rationally at least, that oral antibiotics are at least as good, if not better than IV, but I still see a ton of patients coming back for extra visits to my emergency department just for IV antibiotics. Now you might say maybe I'm just a very bad teacher, but think about changing your practice. Admitting that your previous practice was wrong, it's a big deal. It's not easy to do. So who do you trust to change your practice? Are you going to listen to every person talking at a conference or on a podcast or on YouTube? I doubt it. In fact, I really hope not. How do you know that you can trust that person? How do you know that their interpretation is correct? So I think if you want to keep your medical practice up to date, if you want to practice up-to-date medicine, if you want to practice evidence-based medicine, I think there's only one person whose opinion you know that you're going to trust, one person you'll listen to, and that is you. Which means that if you want to make sure that you're staying up to date and practicing based on the best available evidence, there's only one way to guarantee that. You have to read some papers yourself, at least sometimes. Form your own opinions because you know that there's only one person who you are going to consistently listen to, and that is yourself. So For evidence-based medicine, this whole idea of evidence-based medicine, for it to work, every one of us has to take part. We all have to read and think about papers. Really, you do have to do this at least a little bit for yourself. Unfortunately, for many years, and for many people, we've been teaching this in a way that makes it sound incredibly daunting. I think the average doctor has been brought up to think about evidence-based medicine as incredibly complicated. None of us, myself included, really understands the statistics here, right? These papers use a ton of words that maybe we heard one time in medical school, but we don't use them every day. We feel outclassed, and so we tend to give up. So all I want to convince you is that we've got this all wrong. We've made this needlessly complicated. Science is not complicated. Evidence-based medicine is easy. Every doctor, and this isn't just limited to doctors. Obviously, that's my core audience. I use the word doctor, but any science-trained clinician who sees patients has all the tools that they need to be evidence-based medicine experts. And sure, like anything, you will get better if you practice. The more you do this, the better you'll be. But you already have the tools that you need. Evidence-based medicine is easy. And if you're willing to accept just that, if everybody here starts picking up just a few papers, maybe one paper a month, and you started reading them, your patients, my patients, our patients will benefit tremendously. And look, I know I might sound ridiculous trying to claim that evidence-based medicine is easy. I remember going to journal clubs as a resident. People would talk about regression analyses or I-squared statistics, and I would just sort of nod along and pretend like I understood what the hell was going on. Evidence-based medicine seems very complicated. But I've come to realize that evidence-based medicine is really easy. We just have to relearn how we think about it. So there are 3 major lessons that I think can help you simplify evidence-based medicine and realize that you're already more than capable about picking these papers up and reading them for yourselves. 3 steps today to help you make evidence-based medicine easy. So first, you have to realize that the vast majority of that published paper, the PDF, or if you actually have paper, good for you, the vast majority of that is just not important. You can save yourself a ton of time skipping through the manuscript and just focusing in on the details that really matter. Second, you have to realize that evidence-based medicine is not about statistics. Editors can look at stats, but as a practicing clinician, the stats are going to be the least important part of the paper. And then finally, it's really important that we embrace the full definition of evidence-based medicine, where the literature is only part of the picture. Practicing clinicians with good clinical judgment and the ability to interact with patients are essential to evidence-based medicine in a way that statisticians just never can be. Embrace those 3 lessons, and starting tomorrow, you will be able to confidently read papers. And if you start reading papers, you'll start forming your own opinions, and you'll find that it's much easier to change your practice, much easier to do something that might be a little bit different than your colleagues, much easier to talk to patients about these really complex decisions. And I think ultimately that is going to help all of our patients a lot. So step number 1, we need to relearn how to read a scientific paper. A scientific paper is not like a book. You don't just sit down, pick it up, and read it front to back. If you do that, you're going to waste a lot of your time, and none of us has time to waste. So we need to really understand the sections of a paper to make evidence-based medicine easy for us. So we're just going to run through them really quickly here. So first up, obviously, is the title and the abstract. And these were helpful if you were searching for a paper. These are helpful on PubMed they're helpful if you're doing a literature search. But if you're actually sitting down and you've decided to read a paper, we don't need these anymore. We don't need the quick author's summary. We want to think for ourselves. That's why we're reading the paper. So just skip this part. Next up comes the introduction. And if you know absolutely nothing about a topic, the introduction might be valuable, and there's often interesting information hidden in the introduction. But the thing to keep in mind is that the introduction is not the result of a systematic review. There's not even really much peer review that goes into that. This is essentially just the authors providing us their opinions about the topic, which means there is a ton of room for bias there. And we really aren't sitting down to read scientific papers to hear other people's opinions. We want science so that we can form our own opinions. So almost all the time, unless you're really interested in spending your time hearing about other people's opinions, you just skip right past the introduction. The method section is by far the most important part of the paper. This is literally where the science lives. The results are meaningless unless you have good methods. Now, the method section is often the one that uses the most confusing language. There's esoteric language in there, there's jargon, there's, language that we don't use every day, but a simplified approach is possible, and we're going to come back to that in just a minute. But personally, I always start with the method section, because you can, again, save yourself a ton of time. If the methods are garbage, just stop. Stop reading, throw the paper in the trash, because no matter what you find in the results section, if there are poor methods, it should not change your practice. There isn't any value in reading the results if the methods are garbage. Now, the results section is the second most important part of a paper. This is why most people pick up the paper in the first place. People who don't do a lot of evidence-based medicine often skip to the results, skip right past the methods, and that's the wrong approach, and we'll talk about why. And I'll tell you, most of the time, the results section is pretty straightforward. They just sort of say, here's what happened in the study. But there's two things that I want you to keep in mind, and they both have the same solution. Sometimes we can just get overwhelmed because they literally just throw out hundreds of different results. And sometimes the results section can end up a bit biased because the authors do have the ability to pick and choose what they want to tell us about. We can solve both of those problems by keeping things simple. Just look for 3 things in any trial: the primary outcome, the harms, and then whatever outcome, as a clinician, you think is most important. The authors might drone on and on and on about, a CRP level, but if you just wanted to know whether the patients live or die, skip their discussion and just look for that one outcome that you care about the most, the thing that you, as a doctor, know is most important. Mortality matters, CRP levels don't. Neurologic outcomes matter, hospital length of stay less so. Don't let potentially biased authors guide your interpretation. Look for the outcomes that you know matter the most. Next up, if you're reading in order, is the discussion section. And the discussion section is very similar to the introduction. It's basically the author's opinions about their paper. It's their thoughts, but also therefore their biases. It can be interesting. But the point of reading a scientific paper is to form your own opinions, not just accept those of the authors. So just like the introduction, most of the time you can just skip the discussion section, and then the conclusion section obviously is then just the authors telling us their conclusion. But why would have you wasted all your time reading this entire paper if you just wanted to read the author's conclusion? The reason you're reading this paper is to form your own conclusion, so just skip the conclusion section as well. So hopefully you can see, even though, you might download a PDF, it might be 20 pages long. Even though some of these papers, when you first look at them, seem very overwhelming, we can ignore the vast majority of these papers and really just focus our attention on the few sections that really matter. Reading a paper should not be some daunting proposition that's going to take hours of your time. I read most papers, have a good sense of my initial critical appraisal in, 5 or 10 minutes. You read the methods. If they're crap, you throw the paper out. If they're good enough, then I'm going to scan the results for what I think is most important. It's simple, it's fast. So understanding that most parts of a scientific paper are completely useless, that's step 1 in realizing that evidence-based medicine can be really easy. But unfortunately, we still have to make it through the worst part of the paper, and that's the methods section. The methods section is a slog to read, even as somebody who loves this. It uses all sorts of language that we don't use every day. It's loaded with statistical terminology that most of us don't really understand. This is where most people get turned off of evidence-based medicine. So step 2 in making evidence-based medicine easy is the realization that stats almost never matter. Stats are the least important part of science. We can let editors look at stats, statisticians can look at stats. For us, for practicing clinicians, we can almost always just ignore the stats. In fact, really, the only thing that you need to know about stats is that we basically get them wrong all the time in medicine. There is nothing special about a p-value of 0.05. A p-value of 0.06 is essentially identical to 0.04. They should be treated the same. In fact, the p-values that we use in medicine are such a joke in other areas of science. Like in physics, you don't even get to talk about your paper. You don't talk about your findings unless you get a p-value less than 0.00000003. 7 zeros. Our pathetic little p-values of 0.04 have so much less certainty. And that always struck me as really weird, right? Scientifically, we seem to demand more certainty when we're studying the Higgs boson than we do when patients' lives are literally on the line. And one day maybe I'll make a longer video about p-values specifically. For now, I think the one thing that you need to know about stats is that even statistically significant results in medicine have a high likelihood of actually being wrong. False positives are very, very common in medicine. That p-value, 0.05, has a tendency to be misleading. I really think that you can be very good at critical appraisal, that you can get very good, you can get almost everything you need to out of evidence-based medicine while completely ignoring statistics. And I realize that might upset a few people. You know, somebody watching might have a master's or even a PhD. You might have spent a lot of time learning statistics. But here's the thing about statistics. In order for the stats to matter, everything else needs to be perfect. The analogy that I generally use is a race. So you imagine two people are running a race. Stats are the equivalent of a precise stopwatch. It's fancy. It lets us measure the race down to the 100th of a millisecond. And in real life, in like the Olympics, we tend to worship that stopwatch, right? We display that front and center on the TV screen. We praise the times. A lot like some people praise or worship the p-value. And occasionally, that stopwatch can be really important when we're deciding a very close race. But in order for the number on that stopwatch to matter at all, the race has to be fair in the first place. If one person was running uphill and the other person was running downhill, would you care about the time on the stopwatch? What if they made one person carry 20 pounds of weight on their back? Or they used different start lines or different finish lines? What if one person was on a bike and the other person was running? What if one person was doping using steroids? The stopwatch can't help us at all if the race is inherently unfair. The stopwatch becomes irrelevant. And unlike sports, we don't really care about this one race that happened in the past. We're trying to predict in science whether this is going to happen over and over and over again, right? If I was running a single race against Usain Bolt and that day he happened to have a severe flu or, he broke his leg right before the race, maybe I fluke out a single win, but would you use that to conclude that I'm actually the faster runner overall? Would you bet on me in the next race 3 months from now? Of course not, right? So statistics, the p-value, they are, somewhat important. Just like a stopwatch, if you have a perfectly fair race and the race is close, this is a nice tool that we can use to try to determine the winner. But it is only a tiny part of understanding the literature. It's only a tool. A p-value never defines science or truth, just like a stopwatch is not the essence of sports. And for the average doctor, for the average person practicing evidence-based medicine, just sitting down to read 1 or 2 papers, stats are going to be the least important part of understanding the literature. We can trust our statisticians to run that math for us. Our job is to think about the study and try to decide whether this was a fair race. Because if it wasn't a fair race, it doesn't matter how good the p-value is. You have to throw out the results. Just like you would ignore the results on a stopwatch if you found out that one of the runners was on steroids. And the good news is, with just a little common sense, we can almost always sort out if a study was fair. Now, there are a few tricks, sort of the equivalent of like the designer steroids of the science world, and we can learn about those tricks with time. But most of the time, just showing up, reading the paper, and trying to make sure that one person wasn't running uphill while the other was running downhill, that's going to be more than enough. And with time and a little bit of practice, this gets really easy. But if you're just starting out, you're going to want to have an approach. And I'll tell you, when I was starting, I think checklists can help. I used checklists a lot when I was getting initial practice at this. And there's some really good journal club checklists out there. You can check out the Center for Evidence-Based Medicine or my buddy Ken Milne on the Skeptic Guide to Emergency Medicine have some great checklists. But my problem with checklists is that they are often still used jargon. And so they still can make evidence-based medicine seem more complicated than it really is. So I want to simplify this. And I just want to run through one tool that I think can be a very useful guide to help you read a paper. And again, this has nothing to do with stats. This is all about trying to make sure the race was fair. So I like the RAMMBO mnemonic. And RAMMBO stands for recruitment, allocation, maintenance, measurement, blind, or objective. And it's basically just a reminder of the simple, basic aspects of any trial that we want to think about as we're reading that methods section. And I know those words still seem jargony. They're a little bit complex. They're not. So let's just break it down into the core questions that you might want to ask about a paper. And then if we think about it like a race, and about simply making sure that this is a fair trial, we can see that these are pretty simple. So the R in RAMMBO is for recruitment, and recruitment is really just about asking who was included in this study. You want to paint a pretty decent picture of who was included in any study for a couple of reasons. First, you should really only apply the results of a study to similar patients, right? An adult study may not really apply to pediatrics. If there were only men in the study, the results might not apply to women. A study in the ICU might not apply to patients on the floor or in an outpatient setting. And then second, you really want to make sure that the population seems fair. So for example, you're doing a study of CT coronary angiogram and not a single person in the entire trial dies or has an MI at any point during follow-up. That's not a very good population to study, right? The whole point of doing that test was to try to prevent MIs. And you can't possibly show that it has prevented MIs if we test it in a population that literally had zero risk. And yeah, I'm not making that up. There are multiple CTCA studies out there where not a single person had a bad outcome in the entire cohort, and they still try to use that data to comment on the value of the test. It's just ridiculous. So here are the key questions for the recruitment area. Do the study patients look like my patients? Do they look like the patients that I look after every single day? Number 2, is the study size appropriate? And ideally, the researchers will just come out and tell you, because I'll do some kind of sample size calculation. But you can use the general benchmark that a bigger study is better. It's probably fine. And then finally, were there important exclusions that could affect the results? Did they leave specific did they leave specific patients out of the trial? You can imagine a study of steroids. If that study excluded all patients who had any risk factors for a GI bleed, we might not get a fair picture of the harms of steroids in the real world. So RAMMBO step 1, recruitment. And the key is you just ask yourself who got into the study, who was left out, and does that seem fair? It's pretty easy. And then allocation is our A, and it's very similar to recruitment. We're still looking at the study participants, but now instead of looking at the overall population, we're looking at how it's being broken down into groups, because that's basically the basis for all of our trials. We break patients down into different groups that are different in some way that we know about, and then we compare them. And so the key questions here are, were the groups similar at the beginning of the trial? Really important. If, for example, you were doing a stroke study, you wouldn't want the group getting placebo to have significantly worse NIH stroke scores than the group getting TPA, which unfortunately is exactly what happened in NINS. Next, you want to know if this assignment to treatment groups was randomized, because randomization is just the way to make trials fair. If I skip the bad sports metaphors, you can imagine if you were putting together a rec league basketball team, which would be better for you, playing a random selection of teams or hand-picking the teams you're going to play against? You might be tempted to cheat and play against only the bad teams, right? So if assignment wasn't randomized, it's always going to be at higher risk of bias. But if you find a study that's not randomized, it's worth stopping and thinking about what factors might have made the groups different. We call these things confounders. And so an example would be, we hear all the time that early antibiotics are better in sepsis. But patients have never been randomized to early versus late antibiotics, right? So we need to think about some of the other factors that would be involved here. Think about your practice. Would you ever delay antibiotics on purpose? Of course not. So if the antibiotics are being given late, there's probably a reason for that, right? It might be that the diagnosis of sepsis was just less obvious, or that this patient was more complex, had more allergies, or maybe this hospital or this team just isn't as good or as organized. But the point is, because they weren't randomized, we have to consider all of the other reasons that patients might have received their antibiotics late, and we have to ask ourselves if maybe one of those reasons explains the differences that we're seeing. And this is why practicing doctors really need to be the ones reading studies, because we are the ones with expertise to understand these confounders in a way that, a statistician sitting in their office who doesn't practice clinical medicine just never can. That being said, even if we understand them really well, it's just not possible to identify every single confounder, and that is why randomization is so important. It eliminates those confounders for us. So if recruitment is about asking who got into this race, allocation is just asking who got matched up against who. And in both cases, we're just trying to ask them very simple, common sense questions to try to figure out, was this a fair race? So next up, we have M for maintenance. And what this is really about is now that we have multiple groups and we think that these groups are fair, were the groups treated similarly throughout the entire trial, obviously aside from the intervention specifically that we are studying? We can't have one group running uphill while the other group is running downhill. So imagine, for example, a study comparing BiPAP to face mask oxygen. The results could be equal and fair at the beginning. It could be a randomized trial, but if there's some hospital rule that says every BiPAP patient goes to the ICU, but face mask patients can go to the floor, now the patients aren't being treated the same. And if there's a difference in the results at the end of this trial, well, maybe it's the BiPAP that resulted in those results, but maybe it's not. Maybe it's just the fact that these patients got one-on-one nursing in the ICU or whatever other difference. And so it's really important, aside from the one thing that we're studying, that everything else in a trial is kept the same. Now, I like this RAMMBO mnemonic, but I sort of also hate it. There's two M's. It's not a very good mnemonic, but I hate mnemonics in general. But anyway, our second M is measurement. And here we just want to think about how the outcomes were measured. Are we using the same finish line for everybody in the trial? If it's subjective outcomes, think figure skating or high diving. Were the judges fair? And this is where the end of RAMMBO, the BO, comes in. We want our measurements to either be blinded or objective, or ideally both. And so our key questions about measurements are, were the patients, clinicians, and researchers all blinded to the treatment? Because bias is way more common if people are aware of what groups they've been assigned to. And we also want to know if the outcomes were objective and standardized. Even if the trial was unblinded, an objective outcome like mortality is going to be a lot more reliable than something subjective like a pain score. And then I guess we also want to know whether the outcomes were measured for all of the patients in the trial or just some of the patients. In other words, we want to ask, did they lose patients in this trial, and might that affect the reliability of the results? Especially if you think those patients that were lost might have been different from those that they kept in the trial. And then finally, as part of measurement, I like to add, it's not part of the original mnemonic, but I like to add, were harms adequately measured? Because in medicine, we all have this bias. We want our patients to get better, so we get really focused on the benefits. And we tend to forget that our treatments can also cause harm, to the point where some studies don't even look, they don't even measure harms. And it's hard to trust a study. In fact, it's impossible to judge harm versus benefit if a study doesn't even talk about harms. So the quick summary of RAMMBO is recruitment, who got into the study; allocation, how were the groups divided up; maintenance, did we treat the groups exactly the same throughout the entire trial; measurement, was it blind, objective, complete, did they look at harms. No statistics at all. Simple, common sense questions. Evidence-based medicine is easy. Now, once I'm done with that little RAMMBO assessment, I like to take a step back and just ask myself a couple questions to try to place this individual trial within its broader context. So first of all, why was this study done? Is it asking an important question? Or maybe, does somebody have a vested interest in the outcome? Are they trying to sell me something? What is the motivation here? Second, I ask myself, is the benefit big enough? And again, this is mostly a reminder that we tend to get carried away with tiny benefits in medicine and we forget about the context. What are the harms? What are the costs? What are the opportunity costs here? Could we be doing something better with our resources? And then finally, I like to ask, how does this one study fit with previous research? And I don't always know the answer to that, but no study stands alone. No single study is definitive. So we need to have some sense of what the field of science says on this topic if we're going to interpret this one paper. If there have been hundreds of negative trials before this one positive, you should be more skeptical. And this is one of those areas that journal clubs in medicine get wrong all the time. We tend to focus really in on a single publication, but no single paper has ever stood alone. To understand a new paper, it's really important to sometimes read a handful, even dozens of previous studies to get a sense of how this new paper fits with the broader literature base. So to me, that is the core of critical appraisal. It's easy, it's common sense, it's all about asking a few very simple questions. And we never talked about stats at all. And I'll admit, we could dig deeper than this if you wanted to. We can make this a little bit more complex, and with practice, as you do this more, you probably will do that naturally. But in my mind, our job as doctors is to really just ask, was this trial fair? If the trial was fair, then we can look at the outcomes. And 99 times out of 100, you can just trust the statistician. Yeah, there are times when the trials try to cheat with stats, often when they are trying to sell you something, but those are less common overall than the influence of bias on trials. Your job when you're reading a paper is just to try to determine if you think this study was fair. Because if it wasn't a fair trial, you can just ignore the results. The stopwatch does not matter if someone is cheating. The stats don't matter if the results are entirely explained by bias. Evidence-based medicine is easy. We can read papers quickly by understanding the sections and just skipping to the important parts. We can completely ignore statistics and just read the paper with an open mind using that RAMMBO method or just a checklist to help us with the goal of just trying to determine, was this a fair race? Okay, I will admit that there's one part of evidence-based medicine that is not easy at all, and that's trying to apply the results to a patient in front of you. Because unfortunately, no study has ever been black and white. There is always gray area. There is always a reason that every single study, every single Cochrane review ever has always concluded, the bottom line, more research is needed. And part of it is because science is never done. It's always evolving. Every paper leads to more questions. And then on top of that, clinical medicine is far messier than perfect research studies. Every human being is unique. Every clinical scenario is unique. So even if you think the results of a trial are very clear, it's hard to know if they can be perfectly applied to the patients in front of you. For example, let's say the CRASH-2 trial. The CRASH-2 trial was a very good trial. And as a result, all of us are giving TXA to bleeding trauma patients, right? But it is reasonable to ask, do those results apply equally to everyone? What if your patient, has a single source bleeding that you can easily and definitively control? What if your patient had 3 PEs in the last year? What if your patient is currently on anticoagulation for a pulmonary embolism? Does it matter if they have a big mitral valve clot? What if your patient has a mechanical heart valve? Does TEG or ROTEM matter? Even with a great trial, CRASH 2 answers none of those questions. There will always be tons of complex questions that are just left to the clinician. This is the difficult part of evidence-based medicine, but none of it has anything to do with reading papers. Doctors are all afraid of reading the paper, but that is the easy part of evidence-based medicine. Applying the results is hard, and you're going to have to do that no matter what. When David Sackett defined evidence-based medicine, he said there's 3 pillars. Literature was only one aspect. Evidence-based medicine is the best available literature combined with clinical expertise and patient values. But think about what that really means. Evidence-based medicine is literally your job. It's what you do every day. Reading papers, we've gone over that. That's easy. Applying the results is hard. But who has clinical judgment? Who spends their time speaking to patients to elucidate their values? Can a statistician do that from their office? Can the editor of the New England Journal do it from behind a desk? No. You are the evidence-based medicine expert. You might not have thought of yourself that way, but you've already spent your entire life dedicated to 2 of the 3 pillars of evidence-based medicine. You have clinical judgment. You know how to talk to patients. You already have all the tools that you need to do the hard part of evidence-based medicine. You're wasting those tools if you refuse to do the easy part. You need to read papers so that you can base your clinical judgment on the best available evidence. You need to engage with the science so that you can adequately discuss it with your patients. Now, for the purposes of this video, I've probably already gone way too long. I don't think we need to spend a lot of time discussing the hard part of evidence-based medicine because, again, I think you're already experts. My main goal here was to convince you that evidence-based medicine is easy. Reading papers is easy. Just skip to the good bits. Interpreting papers is easy. Forget about the stats. Just think about, was this a fair race? And yes, applying the results can make things a little bit complex. But you are already an expert in the hard part of evidence-based medicine. Medical training is all about developing your clinical judgment, developing your communication. You are already an expert in 2/3 of evidence-based medicine, but if you want to up your game, if you want to make use of that expertise that you've been training your entire life for, if you want to actually start changing your practice when there is new science, you have to embrace that other third. You have to accept that reading papers is easy, that interpreting papers is easy. And if you do that, you will be an evidence-based medicine master, and your patients will benefit tremendously. Until next time, take care.